Every year in the United States, more than 200,000 men are diagnosed with prostate cancer. Here at the Hollings Cancer Center, an NCI-designated center, we take a multidisciplinary approach to managing your prostate cancer. When you come to Hollings, your case is going to be reviewed by a urologist, a radiation and oncologist like myself, and a medical oncologist, along with specialists in radiology and pathology that focus on prostate cancer. Prostate cancer is divided into 3 risk groups: low, intermediate, and high. We use these groups to help determine how to best treat your cancer. Please remember that the video we're providing today is only a brief introduction to how to have your prostate cancer managed and the options. And the reason we're providing you with this information today is so that when you do come in to speak with your urologist or your radiation oncologist, that you'll be better informed and you'll have a better idea of how your prostate cancer should be managed. Intermediate risk prostate cancer is not the fastest growing prostate cancer, but it's not the slowest. It's the type of prostate cancer that many times we do recommend we treat aggressively for cure. In other words, active surveillance is not a good idea for most gentlemen with intermediate risk prostate cancer. Intermediate risk prostate cancer is defined as a cancer that has a Gleason score of 3 + 4 = 7, or 4 + 3 = 7. And I'll talk a little bit about the Gleason score more in a minute. The other requirement is that the PSA be no higher than 20, usually less than 20. And the patient could also have a palpable nodule that is not more than half of one of the sides of the gland. So those 3 things, a small to medium-sized nodule on examination, a PSA either between 10 and 20, or certainly less than 20, and a Gleason score of 7 are the things that either alone or combined would make one have a diagnosis of intermediate risk prostate cancer. And it gets a bit complicated. So hopefully we'll work through that today. One option is certainly radical prostatectomy. Again, radical prostatectomy is something that I often refer patients for, despite the fact that I'm a radiation oncologist. So it is a good treatment option for a lot of patients who have intermediate risk disease. But patients need to understand also that the cure rates are generally just as good with radiation as they are with surgery. So one can certainly also consider radiotherapy and radiation options when they're trying to decide how to treat their intermediate risk prostate cancer. Radical prostatectomy is a surgery that is definitely not a minor procedure. It requires a 2 to 3 day stay in the hospital usually, and general anesthesia. The procedure can take 4 or 5 hours, and I'm sure your urologist has gone over these things with you. It does require removal of the prostate and some replacement or rearranging of the plumbing. And so there can be some issues after the procedure that can cause patients to have leakage issues. Leakage issues, again, are still relatively uncommon as patients heal up after the surgery, but 5 to 10% of patients can have persistent problems with leakage after a radical prostatectomy. So if we are wanting to avoid a major operation and a 5 to 10% chance of leakage, radiation therapy is a good option for patients with intermediate risk disease. And again, like with other types of prostate cancer, you can choose the choice of treatment based on side effect profiles that you wish to avoid and impact on your life and lifestyle. With radiation therapy, it's going to be a lot less invasive than a radical prostatectomy, but it's more of a process, particularly for intermediate risk patients. And oftentimes we'll consider adding hormonal therapy to radiation therapy when one has intermediate risk prostate cancer. And we'll go through all these options. The 2 types of options that we have when we're talking about radiotherapy for intermediate risk prostate cancer include external beam radiation therapy and brachytherapy. External beam radiation therapy is the least invasive approach, where the patient lies on the table and the machine moves around and aims X-rays or other external beam radiation at the area near and around the prostate. The treatment is painless. You don't see or feel anything. It takes about 5 or 10 minutes, and then you can get up and go on about your business. However, the treatment does take 1 treatment every day, Monday through Friday, for approximately 2 months. So it's more of a process over time compared to the radical prostatectomy. The other form of radiotherapy is brachytherapy or a seed implant. That is an outpatient procedure where the patient comes in the morning and goes home the same day. Most patients who have their procedures done on a Friday morning will go home by noon on Friday afternoon. Oftentimes the patient is back to their normal activities over the weekend and certainly back at work on Monday. Most patients have very little trouble after a seed implant or external beam radiation, but there are potential side effects of any of these treatments, including surgery, external beam radiation, or a seed implant. Side effects from surgery do happen, just like they do with radiation. The difference in these treatment approaches is in the toxicities that may happen and the way people choose between surgery and other treatment options are by the side effect profile that they want to most avoid or that they're most willing to put up with. With surgery, it is a major operation, so you have to stay in the hospital for a day or two. These days, most people are out before 3 days after the surgery is done. You have a catheter in your penis and into your bladder for about a week to 10 days in most cases while you're healing up. When they remove the catheter, there is some leakage that happens sometimes, and most men have some form of incontinence issues right after the catheter is removed, but usually within the first month or two, those leakage issues almost always resolve. Most patients will have very little problems with leakage by the time several months to a year roll by. But there is the possibility that you could have permanent problems with leakage and have to wear a pad or diaper after surgery. The numbers vary from 5 to 10% at most experienced institutions. So you can have to consider that there is a significant risk of incontinence and the need for a pad or a diaper with radical prostatectomy, although most men can avoid that. Now, when they do a radical prostatectomy, they remove the prostate and then they pull the bladder neck down to connect it to the urethra remnant, the two parts of the plumbing that we talked about earlier. When they do that, that affects the bladder shape and the way the bladder works. So there are some bladder irritation symptoms in most patients that I see that have had a radical prostatectomy. Again, these are peaked when the catheter is removed and they usually resolve within a few months. With radiation in general, we are using procedures that are less invasive than radical prostatectomy. Because we're not removing any part of the plumbing, the risk of leakage is very low. Usually only 1 or 2% will have to wear a pad or diaper after the procedure. So leakage is not an issue with radiation. Radiation does cause bladder irritation though, so there can be bladder changes. And unlike surgery, there's also a risk of bowel issues with radiotherapy. Radiotherapy can cause irritation of the bowels, causing you to have more frequent or looser bowel movements after or during and after the radiation therapy is complete. So surgery causes more leakage issues, but radiation causes more bowel issues. The bladder changes can occur with both approaches. So those are the biggest differences between the two approaches, radiation therapy or surgery. They can all cause problems with sexual function or erection. Now, most men who have surgery or radiation for prostate cancer, if they have good erectile function or good sexual function before we start treatment, they have a good chance of having excellent erectile function or sexual function afterwards. So the things that influence whether you're able to continue to have normal or good erectile function and sexual function after treatment, the biggest one is the status of your erectile function or sexual function before your therapy starts, and that's true for either surgery or radiation. So they both have risks of causing problems with erectile function or sexual function. I haven't mentioned cryotherapy yet. Cryotherapy is generally used for older gentlemen. It involves freezing the prostate in an outpatient surgical procedure. The reason I mention it's for older gentlemen is that it has a much higher risk of impotence after cryotherapy or problems with erections than either surgery or radiotherapy. So we usually don't consider it for gentlemen that are still sexually active. When we talk about radiation therapy, there are two general ways to think about radiation therapy. One is external beam radiation therapy. External beam radiation therapy is typically done with X-rays, and there are newer centers that use protons. But the idea is that you lay on a table, a big radiation generating machine rotates around your body and delivers X-rays or external beam radiation from various angles. The treatment is usually very quick. It takes 5 or 10 minutes. You don't see or feel anything. You lay on the table, you get your treatment, and then you get up and go on about your business. It's the least invasive approach to treat prostate cancer. The other approach that is a radiation therapy other than external beam is called brachytherapy. And brachytherapy means placing radioactive material in and around the prostate. So there are different ways to do this as well, but the one that we generally use here is called low dose rate implants or low dose rate brachytherapy done with small radioactive pellets or seeds. This is done at an outpatient surgical procedure. It does require general anesthesia, but patients go home the same day. So you come in the morning and you're usually on your way home by noon. There's very little downtime. Usually you have some hangover from the anesthesia the following day. On Sunday, if we do it on Friday, on Sunday you're a little bit sore, but back to your normal activities. And most gentlemen that have a procedure on Friday for a seed implant are back to work on Monday. So it is more invasive than the external beam treatment, which is the least invasive approach, but it's a lot less invasive than a radical prostatectomy, which requires part of your plumbing to be removed. So on the scale of invasiveness, prostatectomy is the most invasive, but it's a one-time procedure. A seed implant is the next least invasive, but it does require general anesthesia and an outpatient visit to the hospital. If you have external beam, that is the least invasive approach and requires no anesthesia, and it's all done on an outpatient basis. The other side of that coin, however, is that the least invasive approach, external beam radiotherapy, requires 40 to 44 treatments. So it's a little bit of radiation treatment, 5 or 10 minutes a day, Monday through Friday, but it takes 8 or 9 weeks to deliver the whole course. So there's pluses and minuses to each of these approaches, whether you have a seed implant or you have external beam radiation therapy or you decide on a prostatectomy. If we're talking about radiation therapy or surgery, there can be long-term effects from the treatment. Most patients avoid these, but it is possible whether you have surgery or radiation that you could have some problem that shows up months or even years after your treatment is over. The most common one, as I mentioned, with surgery is leakage or incontinence. You can also have problems with erections, as we mentioned, and radiation therapy likewise can have problems that show up later. The incontinence issue is a low risk with radiation, whether you have a seed implant or external beam. But if you have radiation therapy, you could have some other things that show up as the months or years go by. The most common thing that we see is bleeding in your urine or in your bowels. This typically happens, if it's going to happen, about 6 to 18 months after your radiation is over. It only happens about 20 to 25% of the time, so 1 in 5 or 1 in 4 patients will come back and tell me in a follow-up visit, "Doc, I saw some blood in my urine or blood in my stool, what do we do?" When that happens, usually it'll go away on its own, especially if you can avoid constipation. But if it continues to persist, then we need to check it out and make sure we're not missing something like a polyp or some other problem that it's bleeding. If it's bleeding from the radiation, which can happen, we can do a no-touch procedure during the colonoscopy or during the scope that can make the bleeding stop, and usually that's all we have to do. As I mentioned earlier, any treatment for prostate cancer, including radiation therapy, can cause problems with sexual function or changes in sexual function and problems with erections. However, there are a lot of good medicines these days and other things that we can use to improve that problem. So even though we may cause you to have more trouble with sexual function, we have a lot of good ways to make that better. So radiation, like surgery, can cause problems in that area. The risk of something very bad happening with the treatment for prostate cancer is not zero, whether you have surgery or whether you have radiation therapy. If you have either one, it's possible that you could have an outcome that we would like to avoid, that would require surgery to fix or transfusion for severe bleeding or some other problem like that. The good news is that the risk of something this bad happening is very low. It's approximately less than 1% that anything that severe would happen if you decide to have your prostate cancer treated with radiation therapy. When we treat intermediate risk prostate cancer with radiation therapy, and we want to include a seed implant, a seed implant is not done by itself typically for patients with intermediate risk disease. We usually combine a seed implant with approximately 5 weeks of external beam radiation therapy. So one's options include a seed implant plus approximately 5 weeks of external beam radiation therapy, or no seed implant and approximately 9 weeks of external beam radiation therapy. Both of these options have been shown to be effective in treating prostate cancer. One thing I like to remind patients about now is that we've just had a recently reported study that has shown that a seed implant may actually improve the chances of the PSA going down after treatment and not coming back up. What that means is that the seed implant added to 5 weeks of external beam radiation may be better at controlling the cancer than 9 weeks of external beam radiation. The difference is also in the side effect profile. The price we pay for having a seed implant as part of the regimen is that the side effects may be a little bit more severe with a seed implant than with external beam radiation therapy alone, and the side effects may last longer. Now, generally, it's the bladder irritation symptoms that are a little bit more severe and may persist for a longer period of time. When we have a seed implant, remember, it is a minimally invasive procedure, and we actually are poking holes through the skin to put the little radioactive pellets in and around the prostate. So it is minimally invasive, and because of that, you can have some swelling or bruising that you don't have with external beam radiation. In fact, there's a chance that you could have enough swelling or bruising that you may not be able to pee, and you have to come get a catheter placed. Well, the good news about that is that even with a seed implant and a minimally invasive approach, the risk is only about 10% in our hands. So most patients, 90%, will never need a catheter to be placed, even with a seed implant. But it's a higher risk than 1 or 2% that we see with our external beam alone patients. So there is a trade-off. The treatment with a seed implant included is a little bit more severe and a little bit more invasive, and the side effects persist for a longer period of time. But the benefit is that the cure rates, the control of PSA after treatment may be better, at least based on one large randomized trial. In addition to considering a seed implant, if you're going to get radiation to treat your intermediate risk prostate cancer, you have to consider androgen deprivation therapy or hormonal therapy. Hormonal therapy is a medicine that we give you that lowers your body's testosterone production. So these medications are not women's hormones or estrogen, but they're medications that turn off a switch in your body so that your body stops producing the male hormone testosterone. Testosterone is that male hormone that circulates throughout your body that we often see on TV when people are suffering from low testosterone. So what these medicines do is they give you low T, as you've seen on TV, on purpose. The reason we do that is because having the testosterone withdrawn from the prostate cancer kills cancer cells. So just by taking away the testosterone, we'll actually be killing prostate cancer cells. The idea is that we get a twofold benefit from lowering testosterone levels in patients with prostate cancer. One is that it makes the cancer more susceptible to the radiation, so that by giving it ahead of time, we soften the cancer up for the radiation therapy. The second thing that theoretically we may benefit from is that the lack of testosterone circulates throughout your body, so that if there are some prostate cancer cells that are trying to set up shop some other place in your body, the lack of testosterone may prevent them from being successful at doing so. Now, the reason that we say consider androgen deprivation therapy or hormonal therapy is because of two things. One, studies that were done in the past shown that there was a significant improvement in cure rates if we gave hormonal therapy along with radiation in patients that have intermediate risk disease. Now, these studies actually showed that there was improvement in survival, not just control of the cancer, but improvements in chances of you being alive 5 or 10 years later if we gave you hormonal therapy along with the radiation. The question mark comes in because these studies were done in years past when the dose of radiation was a lot lower and it was less effective. So in other words, some people believe that the benefit from the hormonal therapy is no longer significant if we use modern radiation therapy doses that we do every day. So the question comes, are we willing to put up with hormonal therapy when we think it might help, but we don't know how much or if it's worth the toxicity? Most people who are getting hormonal therapy will have hot flashes. Similar to when a woman goes through menopause, they complain about getting all hot and sweaty, lasts for 5 or 10 minutes and then goes away. That's a hot flash or hot flush, and most gentlemen who get androgen deprivation therapy or hormonal therapy will have to put up with that. The other thing about having low testosterone is that it's more difficult to keep off truncal fat, and it's harder to keep on muscle mass. So gentlemen will notice that as the months go by after they start hormonal therapy. The other thing about having low testosterone is you may have less vigor in the gym or less strength lifting weights and things like that. And gentlemen can have diminished sex drive because of low testosterone. So all those things have to be considered if you take a short course of hormonal therapy. There are some other issues that can also come about with the low testosterone state, such as problems with diabetes, cholesterol, anemia, or osteopenia. In fact, if you've had a heart attack before, you're probably not a good candidate for hormonal therapy, because if you've had a heart attack before, it can increase your risk of having another heart attack. But most gentlemen without serious medical problems can put up with the side effects of the hormonal therapy for the 4 to 6 months that they're on it for intermediate risk disease treated with radiation. Intermediate risk prostate cancer should be treated, because if left untreated, it can cause life-threatening problems in the next 5 to 10 years. However, you should also remember that most patients with intermediate risk disease that have their prostate cancer treated for cure never die of prostate cancer. The risk of dying of prostate cancer, if you have your prostate cancer treated with either radical prostatectomy or radiation, even radiation without hormonal therapy, your chances of dying of prostate cancer are less than 10%. So it's very important to remember that this is a problem that you need to manage and not avoid or ignore, but we do expect to cure you. You do have choices, and you should discuss them with the radiation oncologist and your urologist. I also feel it's very important that patients understand that clinical trials are a great opportunity for them and for society. We want to learn how to better take care of cancer, and in this case, prostate cancer. MUSC and Hollings Cancer Center is an NCI designated center, and what that means is our prime goal is to take care of patients the best way possible and to learn how to improve cancer outcomes. I'll urge you to ask about clinical trials regardless of where you decide to get your prostate cancer treatment.